We're live now.
Yeah.
Good afternoon. Thank you all so much for coming out today. My name is Dalton Clark. I'm on here on behalf of Americans for Prosperity in North Carolina. And let me first just thank you all so much for coming out on a cold and rainy Tuesday night. We were up in the boardroom just a second ago talking a little bit about the weather. And I said, you know, as soon as anything's falling from the sky, us here down south, we get a little scared and start driving a little crazy. So I'm so glad to see everybody arrive safe and sound here at the at our NASCAR Speedway Lounge. So right before we get kicked off, I just would like to start with a quick pledge of allegiance. So if you all wouldn't mind rising and join along with me.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. So as we get kicked off here, we have a wide arrangement of organizations that are all going to be here tonight. So we have Camino folks, you might raise your hands to be recognized. Thank you so much for being here. The LIBRE initiative, LIBRE people, where you at? Put your hands in the air. Thank you guys so much. The CVA crew, I see you guys back there. And then Americans for Prosperity as well. So we hear a lot of different angles, a lot of different styles. We hear a lot of people talking about a lot of different solutions to what I think each and every American has on the forefront of their mind right now. How do we lower healthcare costs without compromising the quality of care and having it accessible and personalized for each and every person here in North Carolina? And so throughout the event and throughout the evening, you'll hear different perspectives and different solutions of how we get to what we here at AFP and LIBRE and CVA know is the personal option. So to kick our night off tonight, probably the reason that most of you came out here, we have Lieutenant Governor Mark Robinson. Lieutenant Governor, I'm going to turn the mic over to you now. Thank you so much.
Thank you all for being here this evening. We certainly appreciate you taking time out of your busy schedules to come here and talk about this crucial issue. And as always, I give thanks to my Lord and Savior Jesus Christ because this issue of healthcare. Oh, I'm sorry, guys. Station break. I'm seeing people that I really know, I'm good friends with. So far, what's going on? What's going on, Brian? How you doing? What's up? Sorry, guys. Station break. But it's a very critical issue, not just in this state, but as you know, across the nation. And it's something that we've all got to have a hand in. All of us have got to have a hand in tackling this conundrum that we have found ourselves in this nation as when it comes to healthcare. Now, let me say right off the bat, I am a proponent of the free market when it comes to healthcare. I am not a proponent of Medicaid expansion. I'm not a proponent of the government in any way, shape, or form being in charge of healthcare. That comes from my experience with government. That comes with the history of our government. I have quasi-joked about the fact that the government could not provide clean drinking water to the Marines at Camp Lejeune. And now they want to step into the healthcare arena to provide healthcare for us and our parents, and the elderly, and for the infirm. Our government has a hard time taking care of the soldiers that they send off to protect us in war. I don't think they'll be able to do a good job of taking care of the rest of us. They need to concentrate on what the Constitution has prescribed for them and allow the experts to handle healthcare. Who are the experts? The experts are the people on the ground that do the job every day. And so I'm a big proponent of the free market system. Now, that being said, there are a lot of issues that we face in the state today. One of the chief issues we face is the rural healthcare issue. We see the decline of rural hospitals, how rural hospitals are struggling, and those in those areas are struggling to get access to care. We have got to tackle that problem to ensure that everybody across this state, no matter where you live, whether you live in Charlotte or whether you live in a small town somewhere down east, everybody has equal access to quality health care. That has got to be a priority in this state. We've got to ensure that our veterans receive the care that they have earned. Let me say that again, that they have earned. We shouldn't be sending our veterans telling them they've got to drive 100 miles to go see a doctor. That care should be right there, on the spot, available in every place, no matter what hamlet, no matter what city they live in. It should be available. That's an issue that we have to deal with. And we have got to figure out some of the ways that we're administering healthcare when it comes to things like nurse practitioners. And some of the laws around nurse practitioners. We're really going to have to take a strong look at doing some things different. I'm sure all of you all can have the same story that I had. During COVID, had it not been for nurse practitioners, a lot of us would have been in trouble. They were the saviors a lot of times during those issues, and we really need to take a hard look at this state to make sure that we take every impediment away from them so that they can practice freely and practice and serve the people that they're there to serve without the state standing in their way. There are a lot of solutions, potential solutions to these things. We could increase access to rural health care by allowing out-of-state physicians to treat North Carolinians virtually. We can change the laws when it comes to our nurse practitioners. But here's the really big issue for me again. And I'm going to go back to this one more time. If we're going to find solutions that work, we cannot rely on bureaucrats and ivory towers. We saw what they did during the COVID debacle. A lot of the moves that were made during COVID were just simply, they stifled healthcare. And they caused a lot of people to lose faith in the healthcare system. And why? Because we allowed politics to drive the COVID issue. We did not allow the doctors who knew better to lead the way. On healthcare in this state, we have got to let the medical professionals lead the way. Those folks who are passionate about making sure that their patients get the right care in the right places at the right time for an affordable and at a high quality. I believe that in North Carolina, we have enough intelligent people that we can bring a team of people together to where we don't have to imitate other states and rely on the federal government to bring our folks health care. I believe that we can be innovative. We don't need to imitate. We need to be innovative in this state. We need to lead the way. We need wherever the state is union to look at us and say, wow, that's a program that I can imitate. We need to be the leaders on that. And so that's going to be what I'm going to be talking about when it comes to healthcare. is being that leader in the nation that allows the free market to drive this so that people can have great health care across the board, across the state, everywhere you go. Affordable, accessible, and world-class. That's what we need in the state. Now, the last thing I want to touch on is this. I don't know how many of you all follow me or have seen me in the past, but you may notice there's less of me. There's less of me. Make no mistake about it, I'm still fat, but I'm less fat. And I have a t-shirt hanging in my closet. It's just a plain black t-shirt. And on that t-shirt, there's one word that I made up, and the word is unfat. And when I get down to my goal weight, I'm going to put that t-shirt on and a pair of Speedos. And I'm going to walk down the street showing off my unfat t-shirt and my unfat body. Now, here's why I bring that up. People talk about healthcare being a right. People talk about healthcare being a privilege. Talk about these concepts, but here it is. Ultimately, healthcare is a responsibility. If you look at the major issues that Americans face in this nation, heart disease, diabetes, those things are driven by poor choices, poor lifestyle.
So true.
That's what it's driven by.
So true.
I look at myself. I take a ton of pills every morning. There have been times when I've gone home and struggled to get up my own steps, thinking I might not wake up in the morning. Why? Because I made poor choices in my life. Let me say this and be clear on this. The very first tenet of healthcare is self-care. And we have got to get back to that in this state, in this nation. We have got to get back to being a nation where the first thing you take into consideration when you wake up in the morning is your health. I've taken that step myself. I don't want to be the guy that stands in front of somebody at 300 pounds and say, it's your fault that you're fat. I want to be the guy that stands in front of you as somebody who used to weigh 300 pounds and say that I put in the work, that I led the way, that I showed you it can be done. We can change these behaviors, folks, and we need to as a state and as a nation. If we're going to be innovative, if we're going to lead from the front, we're going to have to lead with that principle, that the very first tenet of healthcare is self-care. We've got to start loving ourselves, and we've got to start taking care of ourselves. So plan on hearing a lot about that from me out of my office. And plan on seeing me in that unfat t-shirt at some point, doing a pose down on Facebook, because it's coming, folks. Again, thank you all for being here. Let's get together and tackle this issue and bring some great health care across this state on the free market end. Thank you all so much for being here. God bless. God bless the great state of North Carolina.
Thank you so much, Lieutenant Governor. Last time me and him were together, we both had a couple more pounds on, and we're getting there. I'm gonna have to get a matching shirt with it, so we might do that job together. Next, I'd like to introduce the president of LIBRE, Mr. Daniel Garza.
Good evening. Thank you, Lieutenant Governor Mark Robertson, for being with us. I'm actually surprised by how many folks I know in this room, so it's a pleasure. I just flew in from McAllen, Texas, where I'm from, and it's a pleasure to be in North Carolina. Great weather you guys are having. My parents, I'm Sagasa, are from a small, I guess you can call it township, right outside of the city of the grand metropolis of Monterrey, Nuevo León, Mexico, and they were about 30 miles away from Monterrey. But they came to America in the 50s. They saw America as the promised land. It was where you could achieve what you could not achieve in your country of origin. Like millions and millions of poor immigrants before them who came to America and did well and achieved the American dream, and not only generated wealth for themselves, but generated wealth for others too. And that has been the promise of America. What my Senator Ted Cruz likes to say, America has to be that country where anybody with nothing from anywhere can achieve anything. And it's like the Lieutenant Governor was talking about. It is our free market system that allows for that to happen, that allows for us to accommodate waves and waves of poor immigrants. If we lose that, I don't know what's going to happen to America, honestly. Healthcare is now almost 20% of our economy. It's massive. It impacts everything. And 100% of us require healthcare at some point in our lives. I'll be quick because I know we have a really strong panel. My grandmother, Marta Garza, esposa de Beto Garza, we were farm workers. I was a farm worker until I was 19 years of age. Apples, cherries, pears, peaches, you name it, I picked it. In California and Washington and Nebraska. And the reason I mentioned my grandmother is because, well, it was my grandmother and grandfather who first started as farm workers, and then, of course, my parents, and then us, my aunts and uncles. Since then, of course, they moved on and up. I recall a story that my grandmother told me once. Small town of Hera, Washington, the Yakima Valley. She was pregnant, and everybody had gone out to work. It was the beet field at that point near Hera, Washington. The closest hospital was about 7 miles out to the city of Toppenish, Washington, small little town of about 10,000 people. Rural area where they had rented a house, and Grandpa and the boys and my mom and her sisters were out in the field. And Uncle Joe decided to be born then and there by herself in a small little house in a rural area before phones or cell phones and computers. She knew she wasn't going to make it if she waited for Grandpa another 4 or 5 hours. So she stepped out and started walking down the country road about to give birth. A farmer was passing by, happened to be white, noticed that she was hunched over in labor, picked her up, drove her to the hospital in the small town of Toppenish, Washington, stayed there until Uncle Joe was born a few hours later, waited until he knew that she was well, drove back with the instructions that Grandma gave him, and advised Grandpa what was happening. And of course, Grandpa raced over. An angel from heaven, honestly, saved my grandmother and Joe from being born in some country road near Hera, Washington. God knows what would have happened. The point is, today, because of innovation, everybody can have access. Nobody has to go through what my grandmother went through. And it's not government, but it does have to set the conditions, prepare the table for innovation, for incredible kind of access and affordability and quality that we know we can achieve. And that's why it's so important that we have this discussion today. So thank you so much. I look forward to the discussion and talking to many of you, if I can, later today. So.
Thank you so much. A couple housekeeping things before we continue. On each of the tables, there's a QR code. If at any point you have any questions you'd like to ask any of the panelists, feel free to scan that with your phone and just fill out the information that it prompts you there for. I can't promise we'll get to all questions this afternoon. Try to keep be respectful of all the panelists' time. But what I will do, if you'll include your email address on there as prompted, I'll collate all those and get those to the panelists as well. And so, next person I'd like to bring to this podium is Mr. Dean Clancy with America's Prosperity. Dean.
Howdy, and thank you. I can be brief because the previous two speakers said almost everything I was going to say. So I'll just sort of add a little filigree on it. I'm Dean Clancy, Senior Health Policy Fellow at Americans for Prosperity. I spend my time promoting what we call a personal option in healthcare. That's our strategy, our vision, and our philosophy for reforming American healthcare so that it costs less and it's better. We believe that you, the patient, ought to have the choice and control you want with the quality you deserve at prices you can afford from the medical professionals you trust. And why do we need a personal option? Because American healthcare is chronically ill. It's too expensive. It's getting harder and harder to see the doctors and hospitals that you want. And unless we intervene, it will inevitably lapse into a single payer coma. There won't just be Medicaid expansion. There will just be Medicaid. We'll all be on it. Medicaid for all. Low quality government-run healthcare where you won't be able to see the doctors and hospitals you want. You'll stand in line. That's what we're trying to prevent. And luckily, we can do it. A personal option is a set of incremental reforms that every state and the federal government can adopt that will remove barriers between patients and care and empower patients as the true consumers of care. The problem in American healthcare today is that the patient is not the customer. The patient is the product. Large hospital corporations, large insurance companies, pharmaceutical companies, device makers, pharmacy benefit managers, and a long list of middlemen you've never heard of who make a lot of money off the system. They're the real customers in American healthcare. So to remove those barriers, we advocate a series of reforms, which we call a personal option, and those include things like making sure that every single American can save and pay tax-free for healthcare. Right now, big corporations get a tax break for providing healthcare to their workers, but you and I, we don't get a tax break when we buy healthcare out of pocket, or if we buy insurance with our own money. Let's change that. Everyone should have a tax-free health savings account that they can use to save and pay for healthcare. Not just now, but in their retirement years. Only about 10% of Americans can do that now. Let's make it 100%. Second, let's make sure everyone has direct access to doctors. Direct primary care, which is a new model of care delivery, where you just pay a monthly subscription to the doctors that you want to see. And guess what? There's no more hidden fees or charges, co-pays, co-insurance, all that insurance-related blah, blah, blah. You just get healthcare. You call them up, you text them, wake them up at 3 a.m. They won't complain at you usually. And guess what? You get referrals for lab tests with discounts and to specialists. And 95% discounts on generic drugs in some cases. Would you like to save 95% on your generic drugs? Well, you can do it with direct primary care because the doctors are buying directly from the pharmaceutical companies, cutting out all the middlemen. A third thing, and then I'm going to sit down. Why not make sure that everybody's health insurance is affordable? Why not be like Liberty Mutual? Get only what you need. You shouldn't have to pay for all the bells and whistles that you're never going to use. The average health insurance premium today in the individual purchase market is $22,000 a year. And you have to shell out $5,000, $8,000, $12,000 of your own money before the first penny of insurance kicks in. It's like not having health insurance at all. That is what Obamacare hath wrought. And it's going to have to stop. Why not have affordable insurance again, where you just pay what you need? So that's a vision, and there's plenty more. Some of the other speakers are going to talk about a barrier we want to remove right here in the Tar Heel State. But that vision, just those first three things, is very exciting. Health savings for all, direct primary care access for all, and affordable, portable health insurance for all. That, ladies and gentlemen, is what a personal option means to us. Thank you.
One additional housekeeping thing, if you haven't signed in, either on a piece of paper or checked in with one of our iPads, before you leave, if you wouldn't mind doing that, please. Thank you so much. Next, I'd like to bring up to the podium from CVA, Tyler Katesi.
Good evening, everyone, and thanks for coming out. I know there's been it's been one of the most packed news cycle days I've seen in several months, and so I appreciate that you're all here to discuss really what is a central issue in the lives of the over 700,000 North Carolina veterans. My name is Tyler Kotesky. I'm the Policy Director at Concerned Veterans for America. And we were founded 10 years ago by veterans and military families dedicated to preserving the freedoms that they fought and sacrificed to defend. Nowhere is this more clear, some of these points that folks like even others have said than in the Veterans Affairs system. North Carolina veterans know what Medicaid for All looks like because they've seen it firsthand in a broken VA system that too often denies and delays the care that veterans have earned defending our country. The North Charlotte VA clinic is a great example. For new patients, it takes 41 days to get a primary care appointment. Beyond that, in an environment where we have more post 9/11 veterans who we have sadly lost to suicide than actual combat deaths in the war on terror, it's unacceptable that at this same clinic, it takes 46 days for a new patient to receive a mental health appointment. That's betraying the sacrifices that our veterans have given our country. And so what CVA has been dedicated to for over a decade now is reforming the flaws of this perfect example of a top-down government-run system where the hope for a one-size-fits-all system really results in one-size-fits-none. Unfortunately, when veterans are forced to use the VA system and don't have options for outside providers, they lack this individual control that the personal option would give people. What CVA has worked to change in our federal policy around the Veterans Administration was to pass in 2018 the VA Mission Act. This was a landmark piece of legislation that gave millions of veterans access to providers outside the VA for the first time to escape these ridiculous and unacceptable wait times and to have the option to go to community providers that better met their individual needs. This is what we're calling for, is giving people more personalized control over their specific healthcare needs. The ways that the VA has made some improvements since this time has been to the extent that it's embraced more choice and innovation. One of the provisions of the VA Mission Act, for instance, was pioneering looking more at telehealth options, which is of course crucial during the COVID-19 pandemic. But if we double down on insisting that our healthcare has to come through a central government provider, we can tell you what's happened at the VA. Apart from these wait times, we've also seen, veterans experience over 20 million canceled or delayed appointments during a global pandemic. Speaking of unacceptable, most of these delayed appointments or canceled appointments had very little signs of follow-up, so we really don't even know the full extent of the impact on veterans. Though we do know that there are several studies out there showing concrete negative healthcare impacts when people have to wait this long. We're talking about delayed cancer screenings, or delayed physical therapy appointments where having that care sooner is the difference between people's lives being markedly better or worse. So when we talk about the personal option, this is about strengthening the choices that veterans will experience too when they go to providers outside of the VA. To the extent that we make the system easier for people to get personalized access and control for providers that can meet their individual needs, veterans and military families. And so that's why CVA supports the personal option. Thank you.
Thank you so much, Tyler. Next person I'd like to bring up to the podium, you'll see on each of your desks or tables, if you haven't received one, grab one from the back. It's going to say permission to care on the front. That is a certificate of need report that our sister organization over at Americans for Prosperity, the foundation, had recently released yesterday afternoon. And so we actually have Thomas Kimball, who is an author on the report. So I'm going to go ahead and invite Thomas up to the podium now. Thomas?
Good evening. I'm Mr. Merrill, and I am an analyst for the Americans for Prosperity Foundation. And as always said, we just released a report on the impact of certificate of need on the healthcare industry in North Carolina. So when we talk about certificate of need, we often find that a lot of people aren't really aware of what it is. So certificate of need is a law that requires healthcare providers to get the permission of government before they add or expand services or facilities or purchase medical equipment like MRI scanners. In order to obtain that permission, they need two things. First, the state has to have predetermined that there is a need for these services. And then second, they have to apply for those services and get approved. But there's a twist because all of the competing providers who currently offer those services get to intervene in the application process. So imagine you want to open a barbecue restaurant in Charlotte, and so you apply to the government to open a barbecue restaurant, but all the existing barbecue restaurants get to chime in. And what are they going to say? They're going to say, well, we don't need another barbecue restaurant because we can provide the people of Charlotte and its visitors with all the barbecue they can eat. So it's going to make it tough for you to get approved to offer barbecue, or in this case, medical services. So the theory behind certificate of need was that by limiting the supply, they could control rising healthcare costs. It had to do with the way the federal government reimbursed states for certain healthcare expenses at the time. That was 50 years ago, when the U.S. Congress mandated that all the states pass a certificate of need law. 12 years later, I believe, Congress lifted the mandate because it became clear that certificate of need did not contain costs or increase access to health care. So we decided to take a look at the impact of certificate of need on patients and providers in North Carolina, and what we found is stunning. We examined certificate of need applications from 2012 to 2022, and we found that the Department of Health and Human Services has denied $1.5 billion in new healthcare investment over that time. But the true value of deterred healthcare over the last decade is actually much greater, because there are services that healthcare providers would offer in cons actions. Not all states have cons. After Congress lifted the mandate, about 12 to 15 dropped their con requirements. Sometimes we call it certificate of cons, CVA. So, so the true value is greater than that 1.5 billion, because there's a lot of these services that the providers would offer, but if there weren't a con regime, they don't even apply with one in place. And there's a couple reasons for that. One, in order to apply, the state has to determine that there's a need for the services that you would want to offer. And who decides the state's need for healthcare? Well, it's a board called the State Health Coordinating Council. And this board is nominated by the governor, and they act as central planners to decide all the health care that people can have in North Carolina. Now, our analysis finds that 15 of the 25 members of this board are employed by or affiliated with healthcare providers that are regulated by certificate of need. So they're incentivized to protect their employers from new competition. They act as industry gatekeepers to limit the supply of healthcare through restrictive need methodologies. And then the second way in which, or the second reason healthcare providers may not apply for certificate of need is that oftentimes it just costs too much. Okay, Application fees range from $5,000 to $50,000 depending on the cost of the proposed project, but the real cost comes from the price of the outside consultants and attorneys that are required or necessary at least to prepare the application, navigate miles of red tape, and to fend off opposition from competing providers. So once the Department of Human and Health Services has issued a decision on whether they approve an application for certificate of need or deny it, the affected parties, which include the applicant or the competing providers, they can appeal this decision. And so when a decision is appealed, essentially it goes to the courts to be litigated and figure out who gets awarded the certificate of need before it's awarded at all. And oftentimes this can delay the provision of new healthcare. So if there was approvals, then it gets tied up in the court. So we looked at appeal that for appeals filed since January 2020, so the past 2+ years, and we found that nearly $500 million of approved healthcare is being tied up in the court system to be litigated by competing providers. And sometimes, this takes years to work out. There's a handout, one-page handout. It's a case study of one of these situations that should be on your tables. There's more in the back that y'all can get on your way out if you're interested. But it's not necessarily the provider's fault, because this is the game that they have to play that's set up by this certificate of need regime that inherently pits providers against each other to fight for government favor. So instead of appealing to patients, providers are forced to appeal to the government just for permission to serve patients, and that's it's kind of backwards. So why do we have certificate of need? Why is it still around when we know that it does not control cost? Well, one common argument you hear is that it allows for charity care. So supporters of certificate of need say that by pushing all the patients to a few providers, they can cover their margins to provide charity care for patients who can't pay. But the evidence there's no evidence to suggest that is true. Multiple studies show that that's not the case. In fact, recently, the U.S. Department of Health and Human Services conducted a joint study with the Department of Labor and the Department of Treasury, and they analyzed the American healthcare system, and they found no evidence to support that certificate of need promotes charity care. There's an organization known as the Mercatus Institute at George Mason University. They recently published a study where they, and we talk about these in our report, but they recently published a study where they compared charity care in states with certificate of need and states without certificate of need, and they didn't find a difference. And then to bring it home, there's another organization called $4 that educates patients about charity care and helps them bring down their medical debt. And they did a detailed analysis of 3 hospital systems here in North Carolina operating in the current certificate of need regime. And they did a detailed analysis of charity care, and they found that it's not very good. So another thing you hear about from proponents of certificate of need is that it ensures access to rural care. But again, the research suggests that that's not the case, and common sense tells you that when you artificially limit supply, you do not increase access. Mercatus also put out a study showing that states without certificate of need actually have greater access in the rural communities to healthcare than states with certificate of need. So to wrap it up, ultimately, the certificate of need scheme exists to protect politically proficient providers from competition at the patient's expense. And with certificate of need, North Carolinians pay higher prices for less access and lower quality care.
Thank you so much, Thomas. Next up, in the same vein of certificate of need, we have someone who is working vigorously at the moment right now to address the problems that Thomas has laid out. So I'm going to welcome now to the podium Mr. Joshua Wyndham from the Institute of Justice. Josh?
Well, thank y'all for being here. Institute for Justice, Elton. So yeah, my name is Joshua Wyndham. I'm an attorney at the Institute for Justice, and IJ is the national law firm for liberty. We litigate across the country in defense of economic freedom. And in particular, I litigate cases involving healthcare freedom. So we've heard about direct primary care. We've heard about telemedicine. I have cases in Texas and in South Carolina about both of those, challenging protectionist restrictions on people's ability to provide those services in those states under their state constitutions. And I'm litigating right here in defense of a physician's right to help his patients against the certificate of need law. So I want to talk a little bit about that. My client's name is Dr. Jay Singleton. He's a surgeon in the New Bern area. And since about 2004, he's had a fully equipped, fully staffed, and fully accredited surgery center, an operating room that he owns and he built right there in New Bern that he can use to provide low-cost, high-quality surgeries for his patients. He specializes in eye surgery as an ophthalmologist. And he has a problem, right? The problem is that the certificate of need law says he cannot enter the market. And as we just heard, it's not just that the government says, send an application and maybe we'll decide if your services are needed. No, the government has decided since, I think, 1995, that there hasn't been a need for a new operating room in my client's area. So there's a single hospital in his planning area, which is a very Soviet-style way of thinking of things, by the way. There's a single hospital in his area that's allowed to provide operating room services for patients. And my client, who is fully qualified, fully licensed, whose facility is safe and ready to go and already paid for, cannot use it to help his patients get lower cost care. And the reason for that? Well, hospitals have lobbied for years and years and years to prevent any meaningful reform to the con law. They are the ones who drafted it in the early 1970s. They're the ones who opposed reform for decade after decade after decade. They show up every single session to oppose reform, and they have filed amicus briefs over and over and over again in this case to try to convince courts that this law is not unconstitutional. And in fact, just as a side note, every time I show up to speak about this issue in North Carolina, and by the way, I grew up 10 minutes down the road, they send somebody. So there's probably somebody here from the North Carolina Hospital Association. If so, we can chat later, catch up. but to make a long story short, our case has been going through the North Carolina court pipeline for a few years now. We filed it during COVID, and we are at the state Supreme Court, knocking on the state Supreme Court's door. We are asking the state Supreme Court to take our case. And the essence of our case is very simple. Yes, the con law is terrible policy. We've heard lots of reasons why that's so. But kind of at a simpler level, the state constitution actually has a provision that specifically prohibits the government from granting monopolies. It's just right there in the Constitution. It's been there since the 1770s, right? And why did they put that in there? Why did the founders put that in there? Because the Crown, at the founding, had a practice of granting monopolies, special economic privileges to favored market groups. There was a monopoly for tailoring. There was a monopoly for card playing, all sorts of stuff. The king liked to dole out favors. And the whole idea of our system when it was founded was that we don't have a king granting favors. We have a free market. We have an open market where people can compete and provide valuable services as they please, as long as they're not hurting anybody. And my client doesn't want to hurt anybody. He wants to help his patients. And I'll just give you an example of that. The hospital down the street, it's 2 miles down the road, by the way. The hospital down the street, where he has to currently perform surgeries for his patients, charges $6,000 for its facility fee alone. So not even including the particular surgery fee that goes along with whatever the operation is, $6,000 just to use the facility. He can provide a cataract surgery in his facility right now if he wants to, he's allowed to, for $1,800, facility and surgery fee included. So we're talking about a third in price reduction, right? But he can't use it. The facility is just sitting there basically unused, and there's not a good reason for this. And at the end of the day, like I said, The state constitution specifically prohibits the government from setting up systems like this, where in his planning area, only one entity gets to provide these services for patients. That's unconstitutional. We're asking the state Supreme Court to take it up. And I'll just say one more thing, which is, the Lieutenant Governor said earlier that one of the biggest problems in our healthcare system right now is that we have, I wrote it down, bureaucrats in ivory towers deciding things. I cannot think of a system that more fits that description than the common law, right? You have a group of, and it's not just the State Health Coordinating Council. They hire mathematicians and economists who sit with their calculators in their offices and they project into the future whether new services are going to be needed. How can they possibly know that using math, right? I mean, you have the iPhone, right? Did mathematicians come up with the iPhone? Did they predict that 5 years from now the iPhone was going to be needed? No, you had a genius innovating, right? And that's how the iPhone came about. We don't get innovation by banning competition. We don't get lower prices from banning competition. We don't get expanded access to services by banning people from entering the market. That's not constitutional, it's not good policy, and it has to go.
We have one more final presenter before we get to the Q&A session. I don't have a ton of questions, but if you want to send those in, please do. Otherwise, we'll just eat the rest of the leftovers and sing Christmas carols. So the last person I'd like to welcome to the stage is from the Camino Clinic. Before I welcome you up, Lennon, I'd just like to talk a little bit about this for just 1 second. It's hard to conceptualize what all you've heard discussed here today. What's the personal option? What does this mean? What does the lack of restrictions, opening it up across borders, personalized medicine? It seems so pie in the sky. It seems like it's not real. It seems like this can't be applied here in the United States. But this organization that you'll hear from in just a second has done it. It's personalized medicine at its greatest, and I'm so thankful for the partnership with you all. I'm so happy to welcome to the stage now Lynn from Camino. Lynn.
Hola a todos, mi nombre es Len Caro. I am the lead community researcher at Camino. And Camino is a bilingual nonprofit organization located here in Charlotte, North Carolina. And we've been a trusted place within the Latino community for the past 20 years. And everything we do is to uplift those in our community. Our mission is to equip people to live healthy, hopeful, and productive lives. And our array of services and experienced staff members are what help us fulfill our mission. We are a people-first, status-second organization, which means that we are also dedicated to conducting studies in collaboration with the Latino community in order to equip them with knowledge and action to promote social and systemic change. I would like to thank the organizers of this event for inviting Camino to inform others of what we do and to provide our perspective on this issue of healthcare. And I would like to give a shout out for thank you for making this event accessible to Spanish speakers. Finally, my parents can kind of understand what I'm saying a few times at events. But it's not only that we only help the Latino community, it's that we can help the Latino community. We provide a variety of services that are bilingual and culturally competent, that are low cost, including a primary care clinic, health services, food pantry, nutrition and fitness programs, workforce development services, and a thrift store. And our data that we collect through Camino Research Institute informs these services. So why do we provide all these kinds of services? Well, at Camino, we approach health as a multidimensional issue influenced by a variety of factors like their environment, the neighborhood they live in, access to education, employment opportunities, in addition to access to health services. And all these factors are included in what public health experts call the social determinants of health. There we go. While the 2020 census indicates that North Carolina is one of the 12 states with over 1 million Latinos, data on Latinos, unfortunately, especially on Latino immigrants, is relatively scarce. And for that reason, Camino Research Institute is currently conducting a strengths and needs assessment on the Latino communities of North Carolina,
to learn not only more about the issues that Latinos face as they relate to the social determinants of health, but also to learn about the assets within these communities as well. This past September, Camino Research Institute released a comprehensive report on Latino population of Mecklenburg County, detailing the results based on 458 surveys and 4 focus groups conducted across the county. And results show that Latinos value entrepreneurship, they value bilingualism as the top 2 strengths of their community. And in addition, results also show that Latinos rely on strong social support networks, either through family, friends, or communities of faith. However, among Latino immigrants, 62% said they did not have health insurance. And to put this in perspective, the overall uninsured rate for the whole North Carolina population is estimated to be around 12%. That's a big disparity. Not having health insurance makes many health services out of reach for Latino immigrants because they are not able to afford it. This is exacerbated by the fact that Latino households earn around 25% less than the state average, making the financial resources even scarcer. And also, in addition, our survey results found that while 75% of participants preferred to speak Spanish, only 25% had a doctor that spoke to them in Spanish. Now, this is important to note because communication with your provider is crucial when it comes to understanding your health, and being able to directly speak with your provider can help avoid confusion. Nevertheless, while Latinos experience such disparities, research from others, as well as our own, indicate that Latino immigrants lack trust in formal institutions. And this is evident in our 2022 Mecklenburg County Needs Assessment, in which less than 3% of respondents say that they first reach out to governmental agencies when they have a need or problem, preferring to turn to more informal resources like familial networks, churches, and community organizations, as well as their faith. Now, to address these disparities, Camino developed a Camino Clinic, which is one service area of Camino Health Center. There we go. Now, Camino Clinic is a bilingual, low-cost primary care clinic adapted to serve the Latino immigrant community. We staff the clinic with bilingual medical assistants and providers to help our community members feel welcomed and be able to directly talk to the staff and doctors about their health in the language that they prefer. Since many of our patients do not have health insurance, we use a membership model in which a patient pays $240 a year, which pays for their first visit and set of labs. If someone is interested in being a member of the clinic but cannot afford it, we do not turn them away. Instead, we meet with the individual and we try to find a price point that is within their needs. If a patient is diagnosed with a chronic disease like high blood pressure, type 2 diabetes, or high cholesterol, the patient is then referred to our health and wellness program, which is called Camino Vida, which is another service area of Camino Health Center. Camino Vida is a health education and wellness program that provides patients access to a bilingual nutritionist and fitness specialists to create personalized plans to better manage chronic disease symptoms and improve overall health. Camino Vida patients also have access to our wellness center, which includes a demonstration kitchen for nutritional education and fitness equipment for exercising. And Vida patients have the opportunity to work out under the supervision of a bilingual certified fitness specialist to participate in group fitness classes. When a patient is enrolled in the Camino Vida program, the first step is an initial consultation, which is a one-on-one meeting between the patient and a Camino Vida staff member. And during this initial visit, Vida staff go over the patient's most recent lab results, and the patient completes a series of assessments related to their current level of fitness, eating habits, and emotional health. And during this visit, the patient and staff collaborate together in setting personal health goals and treatment plans. And while developing the patient's personal plans, Camino Vida staff also help develop these deep relationships with the patients, allowing them to consider the patient's cultural background, like food and physical activity preferences, the barriers they experience to healthy behaviors, and their family life as they develop their plans. Patients meet with Camino Vida staff and complete the same assessments every 3 months so that patients can see the progress they make towards their goals. We also use this data to help measure the effectiveness of the Camino Vida program. And patients receive follow-up phone calls every 3 weeks in between the in-person visits to provide motivational support and accountability. There we go. In addition to individual meetings, patients receive various health education resources, including group nutrition education, cooking classes, and group fitness classes. And Camino Vida helps patients preserve their cultural identity. They do not do this by showing patients how to substitute certain ingredients, but rather asking them, or not asking them to give up certain cultural dishes that they grew up with. For example, I grew up in a Colombian household. I was taught that a proper meal would be sancocho with arepa. But, there are healthier ways to prepare that cultural dish that would be, culturally appropriate for me. So Camino Vida is staffed with bilingual Latinos representing diverse backgrounds, including Colombia, Panama, Mexico, and Puerto Rico. And given their diverse cultural backgrounds, staff are able to connect with and relate to patients on a personal level. In addition to nutritional education, Camino Vida provides patients across access to nutritious foods through our food pharmacy program. Now, according to our survey assessment, 71% of Latinos reported not having enough money left over after paying their monthly bills, which makes it difficult to purchase basic necessities like food. And with inflation going on, you can only imagine that's getting tougher. In addition, almost half of survey respondents said that they run out of food before being able to buy more, and 38% of respondents said they skip or reduce meals before having money to buy more food. So to overcome these economic barriers of access to nutrition, Camino Vida patients are able to access nutritious foods through the food pharmacy program. And in addition, are taught by Camino Vida staff on how to healthfully prepare dishes from the ingredients distributed through that program. The food pharmacy is run by a chef, actually, who works with a registered dietitian to do cooking demonstrations that help families learn how to replicate those cultural dishes at home. Now, Camino Vida has been active since September 2020 and has shown evidence of its effectiveness up to this day. After 12 months, patients saw significant improvements in outcomes, including 34.1% decrease in triglyceride levels, a 53.2% improvement in performing chair stands, which is a muscular strength assessment, as well as significant reductions in stress and anxiety levels. And there's also evidence of significant improvements in BMI, waist circumference, cardiovascular disease risk knowledge, and healthier eating habits. And during focus groups with Camino Vida patients, the patients credit the program for helping them prioritize their own health and not only their work and family responsibilities. In addition, patients also value being directly contacting and receiving frequent follow-up with Camino Vida staff in Spanish because it helped motivate them to continue their diet and exercise routines. So in conclusion in order to understand all these health issues among the Latino immigrant community, it is important to understand it through the social determinants of health. Latinos all across North Carolina are experiencing disparities related to health and nutrition because of a variety of factors, especially those related to access to medical insurance, financial constraints, and language barriers. Organizations like Camino are designed specifically to help overcome these barriers and provide culturally competent bilingual care to the underserved Latino immigrant population. However, in order to offer services like Camino Clinic, Camino Vida, and our food pharmacy, there needs to be more funding dedicated to programs specifically meant for the Latino community. The success of such programs really does rely on having that cultural competence built into the very infrastructure of these programs. This means that you need to have bilingual staff, and you need people who come from Latino culture and really understand what it takes to develop a trusting relationship with this community. The fundings of targeted, culturally specific programs for the Latino community is crucial in order to authentically transform people to live healthy, hopeful, and productive lives. Thank you.
Thank you so much to all our presenters. I'd like to invite you all up to take a seat for a quick Q&A. Don't have a ton of questions coming in, so we'll take this as a nice photo op opportunity and go eat some dessert afterwards. So guys, come on up. Please, nobody slide off stage. Yeah, we don't need that. This event almost went perfect. First question is not to one person in particular, so whoever feels brave enough to jump up here and answer, we would greatly appreciate it. I enroll employees in their company's health insurance. What can be done to lower the high deductibles? Please reach the mic.
I'll jump in since I'm a policy wonk. Part of the personal option is to let employers provide what are called association health plans. This would enable small businesses to group together, purchase insurance benefits for their employees at a much more affordable rate. And we have to remove some federal and in some cases state barriers to make association health plans available. But in such plans, you will have lower premiums. And to lower the deductibles, we also need insurance reforms, because the reason deductibles, that's the part you pay before the insurance kicks in. Those have skyrocketed in recent years because of federal regulations passed as part of the Affordable Care Act, Obamacare. So remove those barriers and deductibles will come down.
I can add just a bit. I can't directly answer that question, but I can tell you that we have ideas on selling our membership and packages for businesses to purchase and then distribute to their employees, especially for employees that probably don't qualify for healthcare. So that is one way that we work with businesses to make sure that Latino immigrants have access to healthcare.
Lena, while you got the mic on, I do have one Camino-specific question. I don't know if you can answer this or how you can answer it compliantly, but how does Camino get their income, and how can patients access their services? Do you have plans to expand into other areas of North Carolina?
Oh yeah, I can answer that question. So we rely on a variety of funding streams. The membership model we use because while significant portion of patients don't have the means to pay that price, and we work with them to find a lower cost. There are Latino immigrants that do make it in this country, and they want to give back. They want to have buy-in. They want to pay the full price of the membership. But we also rely on funding from a variety of different foundations, different businesses invest in us, different health departments have provided funds so that we can continue our expansion into not only Mecklenburg County, but Cabarrus County, Guilford County, Salmon County, those other counties as well.
Thank you so much. Next thing I have here, Singapore has the lowest cost and highest quality of healthcare in the world. Is that a system that we could emulate here in the United States?
I'll jump in on that one. Singapore does have those things. They have health savings accounts for everyone, which is something we're advocating. The only downside is it's mandatory. You have to have a health savings account. You have to put money in it. I don't know that in America we would be as comfortable with that, and I don't think we need it. Singapore is this tiny island where they can get away with that. In America, I think we need just lots more options. That's why we talk about personal option in healthcare, more choice and competition.
And while your mic is hot, would you maybe want to just take a second and kind of explain some of the work that's been done on the federal level as it in regards to HSAs and where we're heading and where we'd like to be?
Sure. A health savings account is a tax-free account you can use to purchase qualified medical expenses out of pocket. You can use it for things your health plan doesn't cover. You can use it for doctors that are not in your health plan's network. It's a great supplement to insurance, and only 10% of Americans have access to HSAs. Does anyone in this room have a tax-free health savings account? Okay, we got a few here. Well, that's great. And we want that to be everybody in the room, because this is money that isn't taxed when you put the money in, it isn't taxed building up, and it isn't taxed when you spend it on health care. It's the most generous tax account in America, and it just makes sense that everybody should have it. And it's like getting a discount on every healthcare purchase. And we're talking about a double-digit percentage discount because the money is never taxed. So is that answering your question? We've got legislation in Congress to make it available to everyone, and we're going to try to get that enacted.
Yeah,
No, Dalton, I was gonna say, going back to the question about what we can do to reduce costs. I didn't want to overlook also the innovation of telehealth, telemedicine. It's just so critical, especially for folks in the rural areas. We had a panel discussion with the Vice President, Mike Pence, like 3 years ago. When we were talking about, this was in Arizona, in Phoenix, Arizona, and how rural Arizona is. And I imagine parts of North Carolina as well, Texas, I mean, forget it. And I was talking about the story of my grandmother. To connect these folks to doctors, specialists, that you don't have to go in-house. That you can also bring specialists that don't have to be in-house in that clinic or that hospital, but connect them to the patients. Has, I think, also created new billing models, affordability, accessibility, quality of care as well, that I think is just terrific and very innovative.
Tyler, I saw you perk up.
Thanks. So I can speak real briefly about just some of the federal issues that CVA is looking at to expand choice for veterans. One thing that we hope is that the more choices that veterans have outside of the VA system, the more they'll be able to take advantage of more choice and access that we can secure here at the state level or federally as well. So one of those bills is called the Guaranteeing Healthcare Access to Personnel Who Have Served Act. And Senator Tillis is actually a co-sponsor of it. And this basically takes what are called the access standards for community care. Community care is options that you have outside of the VA system. And the access standards basically say that if you have to drive too far or wait too long, then you're eligible to have these non-VA choices. And it makes sure that those standards, which right now are set by the Department of Veterans Affairs and can change at any time, make sure that those are codified and permanent so that veterans have the confidence that they can use these more personalized, individualized options outside the VA system. And one thing that we're looking at for next Congress to grow the sponsorship of is also the Veterans Healthcare Freedom Act, which would make sure that you just have be a pilot program to have access to full choice. So meaning that you don't have to meet a certain wait time at the VA or a certain driving distance to an appointment. If you want the choice, you have it to begin with. So you can still use the VA if you like your doctor there, but you can more easily access these options outside the VA as well. Thanks.
Thank you so much. We're gonna have to work on that first bill name. We gotta shorten that up. We gotta come up with a nickname. I'll grab you after. Let me see, what other questions have we had come in here? Thomas, one of the questions we received is, what was probably the most shocking thing that you found in your report? What was the one thing that you saw that you said, wow, I can't believe that? And I know you've done a couple of these in different states, so this one might be different, but take that.
I guess the most shocking was how large the number was. 1.5 billion over a decade in denied new healthcare investment, and we know that just scratches the surface. You got another 500 million tied up in litigation in the courts, and then there's that unseen amount that would be provided, it would be offered. In states without certificate of need, it is offered. But here, it doesn't show up in applications because the providers just don't apply because essentially certificate of need precludes those applications.
Can I say one thing about that? I mean, what I find hilarious is that the defenders of this system in North Carolina often say, well, it's competition. It's just controlled competition, right? You're allowed to enter the system and there's complicated procedures for doing that. So for example, in our case, the Hospital Association has consistently argued that Dr. Singleton isn't banned from the market. He can petition the government to change the need determination. Well, think about how that actually works in practice. To petition the government to change the need determination, you would have to spend a lot of time and money putting together this kind of economic application to show that their formula is wrong, right? Bureaucrat's formula. You take the formula to them, you put the application in, and they weigh it. Usually they reject it. The vast majority of the time they reject it because they're always right, obviously, right? But if they don't reject it, then it changes the need determination for the following year's state medical facilities plan. And for operating rooms, the SMFP, the plan, projects need 2 years in advance. So if you petition to have the need determination changed, that means that maybe 3 years from now, you'll be allowed to apply to compete with other people for the con. It's not competition, it's a ratchet.
And the people you're petitioning to are usually people who are already providing those services and would have to compete with you if they approve your petition.
Who have a lot more money than you because they're already operating. That's the point.
The last question I have here, and I have a feeling Dean's got a great answer for it. How can we address insurance control of healthcare, and is it also responsible for the lack of healthcare?
Insurance companies, they're a necessary evil, but they are an evil. They charge too much and they meddle too much. And the way to solve it is with more choice and competition. If you can have insurance-free options, like direct primary care, like the Camino model that was mentioned, where you're just paying your doctors directly, you cut out the insurance company middleman. When you have an HSA where you're paying for things that your insurance doesn't cover, or that your providers, they don't cover, that's an alternative. I think of the insurance cartel that exists now. It's like the Berlin Wall. And what we're doing with personal option, we're trying to put holes through the Berlin Wall so people can escape. Enough holes appear and the Berlin Wall will collapse altogether.
Yeah, let me add that, one of the most important things when it comes to healthcare for families, of course, is preventative care. Stuff you can be doing to prevent, worse situations. But because of what's happening, because of these cartels, we know that last year, 44% of Americans put off healthcare because they couldn't afford to access it or because it wasn't affordable. So here, they know they have an issue. They know they have a healthcare problem. This isn't even about preventative care. Imagine, what these folks are feeling about preventative care even. They're not even going to the doctor when they have a real issue. It's that kind of inaccessibility to so many Americans is dreadful, which is why we have to expand choice at a much higher level than we have now. And it requires innovation. It does require in a very real way, like in these little Liberty commercials when they talk about, pay for what you need. Pay for what you need. That's what it should be in a very real way, as opposed to, having to purchase what, $20,000 average cost per family and insurance? Already that's driving a lot of people away from having the kind of certainty about healthcare that we should have as families. But even as individuals too, I think we could customize a personal care option where it would dramatically reduce the cost and do away with the certificate of needs that, of course, pushing up costs again and tightening competition.
Amen.
Before I close this out, I'd just like to turn the mic over to the Lieutenant Governor just for a second for any final remarks you might have.
Sure, I want you all to notice something. Everybody on this panel just spoke about the issues that he asked questions about, except one person. That would be me, the elected official. Well, silent. That's what we need. We don't need the elected officials coming up with a solution. We need the elected officials to invite these folks to the table, listen to their issues, examine those issues, examine those things that this gentleman talked about, the impediments that the regulations that he's looked at. Take a deep dive into those regulations. Find out whether or not those regulations are useful or whether they're standing in the way of progress. And if they are, it's our job to remove them. It's not our job to be the experts. We have the experts on the ground every day doing the job, struggling to do the job with their patients and in their hospitals and in their clinics. It's time for the government to take a step back and realize who really runs this nation. The people who run this nation are the people who do the work. It's time that we listen to them and get the government the heck out of the way.
Thank you so much, Lieutenant Governor. We really appreciate this. This has been a part of a series that we've done in conjunction with Lieutenant Governor's office. I can't thank you enough for always being so receptive and fostering good discussion. And so, as we close out here at the end of the day, I'd be remiss if I didn't touch just a little bit about what our vision is here in our organization. And it's breaking down those barriers that Lieutenant Governor's mentioned in his remarks. And secondly, work with anyone to do good. And so one thing I know about each and every one of you out here is either A, you knew we were having a shrimp cocktail, or B, you care about healthcare and you care about fixing these problems. And so I want to thank you all so much for coming and getting involved in the conversation. Before I let you go, I've got just a couple of thank yous I need to do. Jeffrey, raise your hand. Our strategic director, Jeffrey Baldwin. That might be the second most popular man in the room behind all the Lieutenant Governor. Thank you so much, Jeffrey, for everything you do. Jose Ramos, strategic director, CVA. I've got Nicole Sutter in the back. She wasn't paying attention. I think I was going to shout out. Nicole, thank you for everything you do. We greatly appreciate it. Krishana Polite. Krishana with the Lieutenant Governor's office. Thank you so much. Christine, our comms. Christine, thank you so much for everything you do always. And then as we close out, I just want to thank you all so much for coming. We've got some tchotchkes at the back with personal option brand, and Jeffrey's handing those out. We've got first aid kits with the personal option brand on it. Grab you one of those. Jeffrey, if you're listening to me talk really fast on translation, that's thanks to Jeffrey. That was feedback that we received last event that we did. They said, how the heck are we going to do an event in the Hispanic community and not provide opportunities for us to understand what they're talking about? So we took that feedback and have made the investment in moving forward in our LIBRE events. That's something that we'll have available moving forward. Thank you all so much for coming. Please help yourself to the desserts. Take as much food and shrimp as you can stuff in your pockets. Y'all have a good night. Thank you.